text down question over anything like cancer overview, if you want to do over liver cancer, whatever question is pertinent to what we're talking about. And then if it's a good question, potentially I'll put it on the exam, okay? And you have, I think, 2 days to complete that. Where you don't have to do anything, you just got to be patient.
What is this skip thing?
Hmm?
It says something about a skip.
Yeah. That's what you do, the assignment. You don't have to do a skit for your thing. Just talk about how you feel it went, okay? All right, so what do you guys know about breast cancer? I'm sure a handful of you know somebody who's had breast cancer, maybe dealing with it right now, right? It's pretty common. How many women do you think get diagnosed every year? Or let me say this. 1 in every 6 women will get diagnosed with breast cancer at some point in their life. So how many females are in this room? Guys can, but it's 1 in 8. It's much less percentage. What? So about 3 of us in here at some point in our life have a high risk of getting breast cancer, or probably will get it. Pretty significant. It has the most research out of any cancer in general, and still women are dying every day of breast cancer. So why is that? Why can't we catch it early enough and treat it? Okay, not catching it, what'd you say? Just not catching it early.
You don't do self-breast exams.
Yep.
Are you gonna
Yep.
What was it?
Okay, so delay treatment, fear of diagnosis. Maybe they know someone that had it and had a really bad experience, so they're not gonna go in, not gonna do it. I took care of a lady once who had breast cancer that had eroded through her clavicle and was literally eating away of the tissue in her shoulder and her chest wall. And she obviously had been dealing with that for a very, very long time. She was in her 60s, so she wore like zip-up hoodie or like zip-up jackets with hoods, so she could kind of cover this area. She stopped sleeping in the same bed with her husband. She wouldn't change in front of him. She just kind of started secluding herself off from people, partly because this smelled very necrotic and very nasty. As you can imagine, when something necrotic is eating through healthy tissue and killing it as it goes, that smell and nastiness. So her husband just thought that she was like, hated him or was going through some sort of crisis. He didn't really know what to do. Put it off. She actually ended up in the hospital for something else, and that's when they found this like huge fungating necrotic mass, and she obviously had stage 4 breast cancer. But she was too scared, exactly what Ryan said. She had felt a lump 2 years earlier and never said anything about it. 2 years, that's a long time when you have something just growing and getting necrotic in your body. It happens a lot more than you think. Or if people don't have insurance, if they're scared to go in and get screening, scared to go get a mammogram, maybe don't have knowledge, general knowledge that they should, which seems kind of crazy to us healthcare people, that people don't have knowledge that they need to do self-breast exams or they need to go get a mammogram, but it happens all the time. And so people get diagnosed late, or sometimes younger people, they think, oh, I'm too young, it can't happen to me. People who are pregnant, they blame it on the pregnancy, and then they have this surge of hormones, boom, they end up with more of an aggressive type. So lots of different reasons, different diversities. There's a lot of research about like African American women are not as likely to go get screened and will get diagnosed a lot later, and some other cultures too, just because of cultural beliefs. Okay, so what is it? Just like any type of cancer, unregulated growth of abnormal cells within the breast tissue. It's the second most common cancer. What do you think number 1 is? Any guesses?
Well,
What? No?
Skin.
Skin. Yep, skin is number 1. Second leading cause of cancer-related death in women in the United States. So it begins as a single transformed cell. It's a very often hormone dependent. So women have obviously estrogen, right? A lot of estrogen in their bodies. It's stored in fat cells. It helps their bones be stronger. Does all sorts of great things. And so estrogen, we know, feeds breast cancer in certain types if they have hormone dependent, which we'll talk about. So it's either classified as invasive or non-invasive, or you might hear like DCIS, which is ductal carcinoma in situ. So in situ means that it's basically a cancer cell has formed and it's just sitting like in the breast tissue, but it hasn't invaded into the lobulars or the ducts of the breast. It's just sitting there. So that would be very, very early stage because it hasn't invaded yet into the tissue. So most common is invasive, right? So it's already invaded. So you'll hear of like ductal carcinoma, which basically means that there's breast cancer in the ducts of the breast. Carcinoma is the cancer, okay? So invasive ductal carcinoma, that would tell you it's invaded the ducts of the breast and it's cancer. Okay, you can also have invasive lobular carcinoma. That's a little less common, but basically instead of invading the ducts of the breast, it invades the lobes or the lobular tissue in the breast. So those are kind of the two types, carcinoma of the lobules or the ducts. You can also get a different type of just kind of solid tumor called sarcoma of the breast. It's still considered breast cancer, just treated very differently, very, very rare. So yeah, infiltrating ductal carcinoma is the most common and what you'll hear about the most. So it's classified as these different categories. So ER status means estrogen receptor, okay? So that means if a woman goes in, has a mammogram, they see something suspicious on the mammogram, they go in and stick a needle in that tissue, take a biopsy, they look at it under pathology, they look at those cells, and they see, okay, this is cancer, then they can look and see, is it estrogen positive? So they can tell just by looking at the pathology, is there estrogen that's feeding this tumor? The most common type is that women will have estrogen positive breast cancer because you have estrogen in your body, okay? You also can have some progesterone, so women will produce some progesterone as well. And so it can be ER positive, it can be ER/PR positive, or if they don't have any hormone, then they'll say ER negative, ER/PR negative, okay? Most common is that if it has some estrogen, it also has progesterone in there. They use that as a prognostic factor, and they also use it to treat, because we'll talk about treatment in a little bit. They can give pills that will actually block estrogen to that cell so they can prevent it from coming back, okay? HER2/neu is a protein that is seen on a breast cancer cell, and if they have this protein sitting on the cell, it will make it a more aggressive cancer, typically. Sometimes it's seen in more younger women will have triple positive breast cancer. So if you hear that, that's what that means. That they have estrogen on that cell, progesterone on the cell, and they have this protein called HER2/neu. So there's targeted therapies that they can give that will specifically attack just the protein on that cell, the HER2/neu, and basically shut that down, okay? Or if you have triple negative, then what is that? They don't have any of these other three factors. So their HER2/neu is negative, they don't have any estrogen feeding that cell, and they don't have any progesterone feeding that cell. Now, which one do you think is the worst case scenario? To have triple negative or triple positive breast cancer? Triple negative, because we don't have anything except chemotherapy to kill that cancer with, right? If you have positive breast cancer, whether it's just ER/PR positive or triple positive, we have things that we can attack and kill that with, right? So I just told you there's targeted therapies and there is drugs that block those hormones, plus your chemotherapy and radiation that we can use to kill all three of those things. If it's triple negative, then it's typically more aggressive, and we don't have as many, weapons, if you will, to kill it off with. So usually a lot more aggressive if they have triple negative. Usually spreads a lot quicker. It's often found already to be somewhere else, usually the liver. Breast cancer loves to spread to the liver. So if somebody has triple negative, they always will test liver enzymes and usually do a CAT scan of their abdomen just to see has it spread anywhere else. Okay? So we know that sometimes it's caused from environmental risks. So smoking, there is a little bit of correlation to smoking and breast cancer. Alcohol use, there is a correlation to people who drink are at more risk. Hormones, so if anyone went into early menopause or started their menses later on in life, we'll talk about that in a minute. They have more estrogen, they're overweight, those are all risk factors. Or women who are postmenopausal and they take estrogen supplements. So how old are most of your moms?
70.
50s, 40s, so maybe nearing like menopause, right? Maybe. Some may be already there. So you should ask them or educate them on not to use any sort of estrogen replacement therapy. There's a lot of research out there on hormone replacement therapy. Because women who go through menopause, they get hot flashes, they get achy, they get vaginal dryness, they don't sleep well. It does a lot of goofy things to their body. So if they take an estrogen supplement, it helps them feel better. But they're also putting themselves at a greater risk for getting breast cancer. Okay, if any of you are looking for a research project, you could do something like that. There's a hereditary risk. So we know that there are some genetic factors, like if they have BRCA1 or BRCA2. These are chromosome abnormalities that are seen. So if a mom of somebody has the BRCA gene, their kids have a 50% chance of getting that as well. So it's pretty high. Just the chromosome that it infects. You guys don't really need to know the difference between BRCA1 and BRCA2. Just know that if they do carry this gene, they have a lot higher risk of developing breast cancer, and their offspring has a 50% risk. So there's only about 10% or a little bit less of breast cancers that are actually hereditary. So for the majority, it's purely bad luck, or you might have another risk factor. Okay, but there's women who can do everything right, and for whatever reason they get it. Just like any other type of cancer, right? You don't know why it affects one person versus the other. But the hereditary risk is actually pretty small. But if any of you have a first-degree relative that had breast cancer at a younger age, so usually under age 50, they would recommend you start doing breast cancer screenings for yourself earlier, because there is a risk. There's a lot of genes too that the hereditary component probably is a lot higher. They just haven't discovered all these other genes yet, right? Okay, so risk factors, age and gender. So older women who are usually at more risk, or if, like I said, a first-degree relative under the age of 50 was diagnosed with breast cancer, probably increases your risk. So if you have an aunt, a mom, who was diagnosed, more risk, a sister maybe. If you have cancer in one breast, it can increase the risk of them developing it in the other breast, either down the road or at different times. We've seen that. Personal history, so obviously that's what I just said. If they've had Hodgkin's lymphoma as a child, they probably received some radiation to the chest wall, and that radiation can do enough damage to the cells that then later in life can cause breast cancer. So that's a risk factor. If they get their period before age 12, or have children after age 30, is a risk factor. So these are the ones you guys need to know. So first degree relative under the age of 50 at diagnosis, cancer in one breast. Hodgkin's on the child because they probably received radiation, or sometimes chemotherapy. If they receive high doses of chemotherapy as a kid, that potentially can put them at more risk. Do you guys not have this slide? I'll send it to you, sorry. Period before the age of 12, menopause after the age of 55, puts them at a high risk. If they have children after age 30, puts them at risk. Just because they had a change of hormones a little later on. Obesity, because again, estrogen is stored in fat cells. I'll give you guys a second. I'll send this slide, you guys. Sorry, I thought it was on yours. So what can we do to prevent? If somebody asked you, how do I prevent getting breast cancer? What would you tell them based on those risk factors? What would you tell them? Diet and exercise, right? Limit your alcohol intake. Know your family history. So has anyone in your family had breast cancer? Males can get it too. The risk is lower, obviously, but they can still get it, especially if their mom had the BRCA gene. I've known families where the mom had the BRCA gene and the son was positive, but the daughter wasn't. Weird scenario, but it happens. So males should do self-breast exams as well. So maintain body weight, activity, limit hormone therapy, educate women on taking hormone therapy after menopause. There's a lot of controversy out there. There's a lot of natural supplements now that have been tried and tested that are supposed to kind of mimic estrogen in the body, but it's a lot safer. So a lot of new stuff out there like that. And obviously early detection can reduce the risk of mortality down the road. So how are we gonna know? Self-breast exam. So things that they might find is a non-tender lump in the breast. In assessment, we talked about the tail of Spence. So how the breast, it kind of has a tail that goes up into the armpit, right? You guys remember that? So if somebody has cancer in their breast, where do you think it's the first place it's gonna spread? To the lymph nodes up into the armpit, right? Because the body is going to try to recognize, okay, there's something abnormal going on here. I need to get rid of it. So it's gonna try to flush that out, and it's gonna go into the lymph system first. Okay, that's how it spreads, through the lymphatic system or through blood, right? So often found in the upper outer quadrant, but can literally be found in any part of the breast. If they have any sort of abnormal nipple discharge, that could be a red flag. Tenderness not around the time of their menses could be a sign that something's going on. Any sort of rashes around the nipple area or on the breast. There is a type of breast cancer called cutie orange. We talked about this in health assessment. It's a very, it's called inflammatory breast cancer. It's a very aggressive form, and literally the breast will start to look like an orange peel. If their nipple starts to retract, because if you think about it, if you had a tumor sitting inside somebody's breast, and as it grew, starts growing, it's gonna pull that breast tissue in some sort of way, right? So it might retract the nipple inward. So that could be a symptom too. Yes.
Okay, so I know we just talked about how men can get breast cancer too. What types of screenings are there for that?
So if they have any sort of family history, they will recommend they can do mammograms on males. It's just their breast tissue is a little different. Usually they'll do like ultrasound. Sometimes they'll do MRI. They'll just recommend they do self-breast exam. Usually, because males' chests are pretty flat, if they do get it, they usually recognize it right away. It's pretty rare. It's less than it's a very small percentage of them that actually truly get it. I think in all the years I've worked in oncology, I've known 2 males that have been treated for breast cancer. And usually they have surgery and done.
Just to improve.
Yeah, we'll talk about surgery in a little bit. So yeah, other things I watch for nipple retraction, if there's dimpling of the skin, if they have any changes in the nipple, it's usually painless if they get that orange peel look. Sometimes found on breast exam, not always though. Because you can have breast cancer that's less than 1 centimeter sitting in a breast. So if you have somebody with pretty large breast, are they gonna truly be able to feel something that's 1 centimeter? if they have really dense breasts, or if they have a history of fibroadenomas where they just feel kind of cyst in there, are they truly gonna be able to feel something that tiny? Probably not. So not always caught on self-breast exam, but maybe they start to have a different symptom. So we really need to educate on getting their mammograms and screening for mammograms, right? What age should women start having mammograms? 40, at age 40, or if there's any family history, they'll usually start at age 35. Okay? So diagnostics they use, obviously clinical breast exam, so that's a provider, so maybe they think they feel something, they go in into, a lot of times the OBGYN is who women will go to, and sometimes that's who they use for the primary care physician. So a lot of times OBGYNs might be the ones who are clinically diagnosing this, or really doing, maybe the woman's there for their yearly exam, and they say, I feel some difference in this breast tissue. Because how many of you truly do breast exams every month? Right? I don't see very many of you, or you don't want to admit it. I would say if you survey the general population of, yes, I check my breast in the shower once a month, a week after your period is when it's recommended to do it, the majority would be like, no, I don't. Right? It's just not something that women ingrain in themselves to do every single month. So you really should educate people to do it every month, a week after their period, same day, right? Some people can't even remember to change their toothbrush every month, right? Let alone do like self-exams. And that's for any type of screening. So good education that they should be feeling, do they notice any changes? Okay? So they obviously use mammography. So this is just kind of an interesting picture of how it has evolved through the years. Now there are certain cancer centers. American has 3D mammography. So women with really dense breasts, sometimes it's really hard to see, especially if they have a really small tumor. So there has been women that have maybe felt something different or gone in for a screening mammogram, everything was normal, and then maybe a month later, they start to notice a change in their breasts, and it was missed on their initial mammogram. So mammogram is not always 100% either. They can do MRIs as well, which gives them a little better picture, but unfortunately insurance won't always cover it. Which is pretty sad to think that insurance dictates a lot of diagnoses in our life, but it really does. So if they do see something, then they do what's called either a percutaneous needle biopsy, so that's where they literally just take them to interventional radiology. They put some lidocaine around the area. They are awake. They put a very large needle with kind of a pincher thing on it into that breast tissue, pull out some tissue, send it to pathology. And a pathologist looks at it under the microscope, and they're looking at, okay, is there cancer in that cell? Do we see estrogen on the cell? Do we see that protein on the cell, HER2/nul? Is there progesterone on the cell? So they can tell a lot just from a simple needle biopsy. Very painful for the patient that has to go through that. Okay? Or maybe it's in a spot where they can't very easily get to with just doing a needle as an outpatient, where they might have to actually go in and do an excisional biopsy. This is where they take them to surgery, and they'll actually open them up and take a biopsy that way. So that's called an excisional biopsy. I would say 95% of the time they do just a needle biopsy for diagnosis, because they want to know what they're dealing with first. Okay, so then they have this breast cancer diagnosis, now what? Now what are they going to have to decide? So then they have to decide what kind of surgery they want to have. And so they can either do a mastectomy, where they remove the whole entire breast. So years ago, in like the early 50s, 60s, if women were diagnosed with cancer in their breast, they used to do a very, very invasive surgery, where they literally took the whole breast, part of the chest wall, they would take the whole pectoralis muscle out. It was very invasive. They didn't know better at the time. They just thought that there's cancer there, it's gonna spread, so we have to take as much tissue as we can. So if you lost your pec muscle, you lose the ability to use your shoulder correctly, right? mobility. So women were being pretty debilitated from this major surgery that they thought at the time was the right thing to do. Now we are much smarter and they know much more that they don't have to have this huge major surgery. So it really is the patient's choice. If they want to have the whole breast removed, they can choose to have both breasts removed. So even if they just have breast cancer on one side, maybe they're like, I'd rather just have both breasts removed, that I don't have to worry about it coming back in the other breast, or I don't have to worry about going through this again. Some women have that mentality. I'll just get both breasts removed. I can get reconstruction if I want, or I don't really care. Okay, so they have that option. Or they can do a lumpectomy, or what's considered like a simple mastectomy. So that's where they basically just go in and remove just the tumor and a little bit of healthy tissue around it. So they basically take out the lumpectomy, or simple mastectomy, or segmental mastectomy, basically the same thing. Treatment-wise, or I should say prognosis-wise, it has been proven that if somebody has a mastectomy, or if they have a lumpectomy with radiation, it is the same prognosis, okay? So if a woman decides, I want to keep my breast, I just want the tumor removed, then they have to still have radiation to the area where it was. Because cancer cells are very tricky, very smart, rapidly dividing. So if they go in and just remove it, there is a very high chance that they left a tiny little cell behind that is going to come back. So they radiate the tumor bed, or where those cells were, if they just have the lump removed, so that they can have the best prognosis they can. Okay, so women's choice if they want to have mastectomy or lumpectomy with radiation. Those are really the two major surgeries, and then they can decide if they want to do reconstruction or not. That is their individual preference. Sometimes women will make their decision, say that you live 2.5 hours away from a cancer center, and you had a small tumor, but you were gonna have to come for radiation, drive 2.5 hours one way for 6 weeks. Maybe that doesn't fit into your life, right? You have to drive 5 hours for a 10-minute treatment for 6 weeks, every day, Monday through Friday. Maybe in those cases when we'll decide, I'm just gonna have a mastectomy, take my whole breast, then I don't have to come for radiation. So it really is a personal choice. So is reconstruction. They kind of have a choice if they want to have reconstruction or not. If they choose to have a mastectomy, there was a law passed probably 10 years ago that if a woman chooses to have a mastectomy with reconstruction because of cancer, insurance has to pay for that. Nurses went to legislature and fought for that to get passed. Interesting story, they used to cover for men who had testicular cancer and would have their testicles removed, they could get a prosthetic testes and insurance would pay for it 100%. Insurance was not paying for reconstruction for women who had breast cancer. So a bunch of nurses said, why do men get this, women don't? So now it's, in all states, they have to pay for it. Just kind of a side note, not something you have to be tested over, but really it's their choice if they want to have reconstruction or not. If they choose not to, there's lots of different prosthesis. So they can get bras that have like pieces in them that they can fit that make it kind of match their other breast. Or even if somebody has really large breasts and they have a lump removed and they don't have a good cosmetic experience that they're left with, they can go have reconstruction done, or there's different devices they can put in their bra so that it looks even. Okay? Neoadjuvant versus adjuvant. So neoadjuvant means that they go to surgery first and then have chemo afterwards. So that's probably the most common. But if somebody has a really, really large tumor in their breast, they might try to shrink it down with chemotherapy first and then send them to surgery. Sorry, that's neoadjuvant. If they have chemo first, adjuvant is the standard of care, or what they normally do. So usually they have surgery right? And then they do chemo or radiation after. But if they have chemotherapy before surgery, it's called neoadjuvant. Okay, so that's a term you guys might hear, that's what it means. Basically, they have chemotherapy before any sort of surgical procedure for cancer. Neoadjuvant. So if somebody has breast cancer surgery, what are some nursing interventions you think it would be important for you guys to know? If we're taking tissue out of an area, what's gonna happen to that area when the tissue is gone? It's gonna fill up with fluid, right? So a lot of times they go home with a JP drain. Typically, breast cancer surgery is done on an outpatient basis. So they're usually not, they don't have to stay in the hospital. They will go home usually with JP drains in place. So you have to educate on a JP drain, right? So what sort of education do you guys need to give if they have a drain? Okay, monitor for signs and symptoms of infection. Measure how much comes out. Usually when it gets less than 30 cc's for a 24-hour period, they can pull the drain. What is also important to educate people on a JP drain?
Squeeze it.
Yep, it has to be compressed for the suction to work, right? If it doesn't, if it's just sitting there as a bulb, it's not doing its job, right? It has to be compressed so it sucks that fluid out. Okay, monitor what the fluid looks like. So it should kind of be serous and then start to get more pink or yellow or more clear the further they get out from surgery. So if they go home and all of a sudden their JP drain is full of blood, that would be very alarming, right? This is not a surgery where they lose a lot of blood. It's not the breasts are not vascular. So really shouldn't be much risk for bleeding. So if they did see a lot of blood, then maybe there was bleeding that happened inside that's now trying to drain. So that's something they need to report. Okay, so let's talk about pharmacologic therapy a little bit. So tamoxifen or Nolvadex, this is an oral medication that is given to block estrogen. So this is given to women who are pre-menopausal, which makes sense, right? They haven't gone through menopause. Their body is still making estrogen that we know if they have positive breast cancer, that estrogen is feeding that cancer and also puts them at more risk for that cancer coming back. So anybody who is hormone positive, premenopausal, they will take Nolvadex for 5 years after they're done with their treatment. And that helps prevent this cancer from ever coming back, is the goal. They used to have them on it for 10 years, and they did some clinical trials and some research that showed being on it for 5 years was just as effective as being on it for 10 years. That's the Nolvadex, the tamoxifen citrate. Okay? So this is a drug that will deplete the calcium from their bones. So what would we have to educate women about? Osteoporosis. Okay, so before they're started on these drugs, they have to have a DEXA scan, so to see how strong their bones are. And then they usually have to take a calcium supplement while they're taking any of these drugs that block the estrogen. Okay, so important to tell them. It can also cause weight gain. It puts them at risk for blood clots. So you as a nurse would want to educate, if you've seen it on this, that they need to increase their activity level. And also, how would you educate somebody to monitor for blood clots, like DVTs? Yep, if they have any redness, any swelling in one leg that's bigger than the other. So it puts them at risk of, having blood clots, weight gain. They can obviously, if you're blocking their estrogen, you're basically putting them into like a menopause, right? So they can have the same signs and symptoms of any woman that's going through menopause. So that can be very hard for them. They can get really achy, they can have fatigue, they can have hot flashes, night sweats, just symptoms that are very uncomfortable. And so it's important that they know that. Sometimes the longer they're on it, then the symptoms will lessen. But it's important education to give to them, because this is what will help prevent their cancer from coming back. Okay, so they're started on this Nolvadex after they've completed the rest of their treatment. So whether that's chemo, surgery, radiation, or a combination of all of those things. Okay? So trastuzumab, or Herceptin, what do you think this targeted therapy does? What do you think this drug targets? HER2/neu, Herceptin, HER2/neu. Okay, trastuzumab. I don't think you guys will ever see that drug on the NCLEX, but you might hear it out in the general public. So if they are triple positive, where they have estrogen on the cell, they have progesterone on the cell, and they have that HER2/neu protein, this is a drug that they can use to block that protein. So block what's feeding that cancer. Okay? So what do we do for women who have already gone through menopause and they're postmenopausal? Then they get these drugs called aromatase inhibitors. So I guarantee somebody has given one of these drugs in clinical, and maybe you had no clue what it was for. Sometimes in the clinical setting, they're labeled as like a chemo drug. It's not really chemo, but letrozole is probably one of the more common, and anastrozole, exemestane, they're all aromatase inhibitors. So they are blocking the estrogen for postmenopausal women. So you might say, wait, they're postmenopausal, shouldn't they not have estrogen? Even though they're postmenopausal, their body still makes a little bit of estrogen. Not as much as obviously if you're a premenopausal, but they still make some estrogen that potentially could be enough to feed that cancer, if there's any left in their body, and cause it to come back. Okay, so these drugs, same side effects, fatigue, achiness, they can have hot flashes. So sometimes women will go on these and they have a hard time handling the side effects, so they'll try different ones until they find one that works. But basically these are just used to prevent the cancer from coming back within the first 5 years. Because in the cancer world, once you've been cancer-free for 5 years, that's when they truly consider kind of the golden standard that the risk of it coming back drops way less after the first 5 years. Okay? And then they also use chemotherapy. So on last week, when I showed you guys that video about chemo, which drug do you remember was red in color, caused the red side effects? What? Doxorubicin. Ruby red. So that is a standard drug that most women with breast cancer will get for chemotherapy, called adriamycin doxorubicin. It's red in color. Anyone that's had this, they'll call it the red devil, because it makes them feel horrible. It has a lot of side effects. They will lose their hair. They will be super nauseated. It's a very potent drug. It can affect their cardiac. So anyone going through chemotherapy and getting, for breast cancer, they have to have an echo before they start treatment. And they'll usually do echocardiograms throughout their treatment, and then even after treatment, because they want to make sure that their heart wasn't damaged from the chemo. Okay? Then they could also have radiation. So if they had a lumpectomy, then they will always have radiation following, usually for 6 weeks. So they do 6 weeks of radiation to where the tumor was. Sometimes if a woman had a really large tumor and they had a mastectomy, so say they had small breast, large tumor, and they're gonna have to take enough tissue that really it doesn't leave them with much breast tissue left, then sometimes they'll have to do a mastectomy, okay? Or if they have lymph nodes that are involved around the chest area, they'll get radiation even if they have the whole breast removed. If it's a really large tumor and there's concern that maybe it's invading the chest wall or the muscle, then they'll still recommend radiation for people who had a mastectomy, okay? But those with a lumpectomy, they usually do have their surgery, then they'll do chemo, and then they'll do radiation after they've had chemo. So that's usually the pattern Okay, so what kind of things do we want to educate them on? No lotions, no direct sun exposure. So if you live in South Dakota, probably not as big a deal, but what if somebody lives in sunny Florida or Arizona and they have a pool in their backyard and they're used to sunbathing all the time? That skin, if it's exposed to sun, skin that's been radiated will become way, way worse. So skin is a huge thing. Sometimes they have to give women a break if their skin becomes too broke down or irritated, because eventually this will open up and they can get like wounds on their skin. So sometimes they'll give them a break. So the radiation they use to treat the tumor bed, it kills any leftover cancer cells, is the theory behind it. They usually do it for 5 or 6 weeks. Same time every day. Treatment usually lasts less than 10 minutes. So sometimes they experience fatigue and then skin changes are the biggest thing. They can also use it, obviously, to treat if they have metastasis. So if they have lymph nodes involved, sometimes they'll use radiation where those lymph nodes were to, again, prevent the cancer from ever coming back. Okay? They can also do radiation called mammocyte. So this is where at the time of surgery, when they take the tumor out, they can put a catheter in that looks like a big balloon, and they deliver a big dose of radiation right into the breast, right after they remove the tumor. You don't see this used very often because it hasn't been as effective. They sometimes have problems with healing, and there's a lot of contradiction out there of should you radiate freshly cut open tissue, right? Should you put radiation to something, skin that has recently been irritated by surgery? So sometimes they have a lot of healing issues, but this sometimes is used like the example of somebody lives 2.5 hours away and they would really benefit from having some radiation, but they can't, maybe they have no way to get to treatment, they have no transportation, they have no family that can drive them. They can do kind of this one high dose treatment to that area and then they're done. Kind of like they do with high dose for like prostate cancer. Okay? So what kind of things are we going to do on assessment? So family history, do they know their history? Anyone in their family had cancer? At what age did that person have cancer? Again, if they were less than 50, puts them at more risk. Most of the time it's just bad luck. Have they had any changes in their breast? Do they do self-breast exams? Have they ever taken any sort of hormone replacement therapy? What is their menstrual history? Do they know what age they were when they got their period? Remember, if they got it before age 12, puts them at more risk just because they've had estrogen in their body for longer periods of time, right? At what age did they have their babies? Women who breastfeed, it actually decreases the risk of breast cancer, no matter what age they had their kids. So did they breastfeed? Because that will actually decrease their risk. Did they drink alcohol? What is their diet and activity like? Did they notice any changes in their height and weight, any lumps or bumps anywhere, any changes in their breast? Those are things you're going to ask them. So obviously a lot of diagnosis can go in here. So if they have surgery, risk for infection, so we're going to be educating them on monitoring the surgery site, how to take care of those drains if they do go home with a JP drain. Obviously some psychosocial things like anxiety, decisional conflict, grief. Disturbed body image is a huge thing. For some women to lose their breast, it's very, very hard. For some women, it doesn't bother them at all. So really it is their personal preference. Some it doesn't bother them, but they think like, what will my spouse think if now I don't have my breast anymore? Or they're lopsided, or one is missing a huge chunk because I had to have this surgery. Okay, chemotherapy, they will lose their hair. So a lot of people will refuse chemo because they don't want to lose their hair. So a lot of education has to be done on that, of you're willing to let yourself die potentially, or this turn into a more aggressive later stage cancer that will kill you because you don't want to lose your hair. That is a very real thing, very hard. They don't only lose the hair on their head, they will lose their eyebrows, they'll lose the hair in the cilia in their nose, so they can have, their nose will constantly run. They will literally lose hair everywhere, okay? So somebody has really long hair, your hair only grows about maybe 1/4 of an inch every couple weeks. So somebody with Taylor, it would probably take at least a year or more for your hair to get back to where it is if you lost all your hair from chemo. Sometimes chemo can change the texture, the color of their hair. So there's women who never had curly hair, and after chemo, it'll come back really curly, or it'll come back a totally different color, different texture. Weird anomalies, right? So you really have to talk to them of, you know, how are they doing emotionally? How do they feel about losing their hair? It's not something that they get chemo one day and it falls out overnight. It usually takes about 2 weeks before it really starts to kind of fall out. Okay, risk for injury. Remember I said the two things that are probably going to kill somebody, bleeding or infection, right? So they monitor their blood counts. Their chemotherapy for breast cancer can make their blood counts extremely low. So they are prone to becoming neutropenic, which means they don't have any absolute neutrophils to fight off any sort of infection. So they have to monitor for fevers. Be cautious of like crowds. Be cautious of being around people who are sick. Bleeding precautions. So if they went in for a simple procedure, you have to make sure that their blood counts are okay. They're prone to anemia because their red blood cells can get lowered from their treatment. So some goals you'd want to do with them, that they don't experience infection, so educate them on those. Make sure they make informed treatment decisions, and it really is their choice. Let them decide, express their feelings regarding their diagnosis, treatment, prognosis, that they receive appropriate support from their family and significant others. Do they have a supportive family? If they need radiation, do they have someone that can drive them to these treatments? If they're coming to chemo, do they have someone that can bring them to chemotherapy? Because they really shouldn't drive home afterwards. They might not feel well. Educate them on if they're on aromatase inhibitor or if they're on Nolvadex, those side effects from those drugs, and that they have to take them consistently for 5 years to be effective. And if they choose not to take them, that they're putting themselves at risk. Also educate them they still need to continue to do self-breast exams even if they've had treatment. Even if they've had reconstruction, they need to continue to do those self-breast exams. I've seen people who've had implants placed and then their cancer came back underneath the implant. It can happen. Okay, so diet, obviously we talked about, they need higher nutritional needs. If they have drains, how they're gonna take care of them. Infection, some of this is competitive. How to take care of their skin if they have skin breakdown from radiation. And how to monitor their skin. Again, avoid any deodorants, anything that's going to irritate that radiated skin even more. Educate on lymphedema. So anybody who has breast cancer surgery, I alluded to this last week, they do what's called a sentinel node biopsy first. So when they go in for either the lumpectomy or the mastectomy, they have to know are any lymph nodes involved. And sometimes it's not something you can see on a scan. If they're not huge and bulky, you won't see them. So they have to test them with dye. So they will take dye, inject into their nipple, and then they'll watch under radiology where that dye goes, which lymph node sucks that dye up, and that's called their sentinel lymph node. So at the time of surgery, they'll go in and take that lymph node out that absorbed this dye, and if it's positive, then when they're in surgery, they will go and take more lymph nodes around them and test them to see if there's cancer in those lymph nodes. Because remember, the staging, when we talked about the TNM staging, how many lymph nodes are involved determines what stage they have, right? So if just the sentinel lymph node is involved and they they take some other ones around it and none of those are, then they still are considered to be an earlier stage. But if the sentinel node lights up, or sometimes if they have multiple lymph nodes, all of them will absorb that dye. And then they know, okay, there's more lymph nodes involved. So they used to, years ago, if anyone had breast cancer, when they did surgery, whether it was lumpectomy or mastectomy, they would do a complete lymph node dissection and would take as many lymph nodes as they could. Well, the problem with that was, what if they didn't have any lymph node involvement? Now we have just disrupted their whole lymphatic system. Okay, which then can lead to lymphedema. Then that lymphatic system doesn't do its job, it doesn't work right, it can get really inflamed and swollen, and they can get lymphedema, where they have major swelling in one arm, the arm that was affected. So you've probably seen patients who wear like a pink bracelet on one of their arms, which means you can't take any blood pressures, you can't do any IVs in that arm. You really shouldn't do anything that would manipulate that arm because you can actually cause them to have lymphedema. So they can get lymphedema anytime between when they had surgery for any time after that. So somebody who's had cancer surgery with lymph nodes removed, 10 years from now, you could put an IV in that arm, and if you infiltrated it, you could cause them to have severe lymphedema. So it's a lifelong thing that they have to be aware of. Okay, so to prevent it, right after their surgery, they want them to continue to move that arm around. So good education will be like, unload the dishwasher, or do simple range of motion exercises so that they're moving that arm around so that it doesn't get swelling and lymphedema in there. Very important, because if they go home and they, well, I had this surgery, I'm not gonna move this arm, they can actually get like a frozen shoulder where they won't be able to move it, or they can get terrible lymphedema, or they can get what's called porting, where they get this extra tissue kind of in their armpit and it can cause extreme pain. So very important to educate them after breast surgery that they need to do some simple range of motion, whether it's just raising their arms up above their head a couple times a day, or unloading the dishwasher, or just doing kind of some simple range of motion so that they try to prevent getting lymphedema or any further problems on the side that they took the lymph nodes from, okay? Because once they have lymphedema, it's very hard to get rid of. So they can wear like compression sleeves. They have machines that they can use, kind of like a SCD machine that will kind of compress and try to kind of squeeze that fluid out of there. There's massage that they can use for it. But the best thing we want to do is try to prevent it before it starts, okay? So keep that arm elevated above the shoulder. Maybe wear a band that says no blood pressure sticks, nothing in that arm. So what if you had somebody that had bilateral breast surgery? How would you know which arm to use? They have both breasts removed. Yeah, ask them, did you have lymph nodes removed from one side, or what was the affected side? Where was your cancer at? Now, some people are diagnosed with both breasts are involved. Then we would have to like take blood pressures on their leg, or ask, do you know which one had the least amount? Sometimes you don't have a choice, right? But you want to try to prevent lymphedema as much as you can. Okay? Promote their psychosocial well-being. We kind of already talked about some of these things. The more educated they are, the better they're going to go through it. It's very common for women after breast surgery, they'll get kind of phantom pains where that breast was. No different than if somebody cut your leg off and you had an amputee, you can get like pain where that leg was. They can get that same pain in the breast. They also can get like these nerve pains where they call them little zingers. And sometimes they think, oh my God, that's my cancer coming back. No, it's not. It's just you're recovering from surgery, right? So important to educate them on that. Help get them set up, you know, if they are gonna lose their hair, do they wanna get a wig? Do they have somebody who can shave their head for them? There's a lot of salons that will do it for them for free that are paired up with the American Cancer Society. So just make sure they have the resources they need. And then try to have them experience the least amount of complications from their treatment, the least amount of side effects from medications, whether it's chemo or from their estrogen blocking medication, that their pain is controlled, and that they have a good understanding of their treatment plan. So some takeaways: they have a history of breast cancer. When was it? When were they diagnosed? How old are they? Women who have had chemo for breast cancer have a much higher risk of developing leukemia down the road. Taking care of women who've gone through breast cancer and then like a year or 2 years later died from leukemia. Very, very sad. But because we know that chemo is a carcinogen, it's very toxic to cells, it potentially puts them at risk of developing other cancers, unfortunately. What side was their surgery on? So we know where we can take blood pressures, where we can put an IV in, where we can draw blood from, family history. What treatment did they receive? Did they receive cardiotoxic chemo? Do we need to be aware of monitoring their heart, making sure that they don't have cardiomyopathy or that they don't have a low ejection fraction from chemo that they received years earlier? Because they can get cardiotoxic years down the road after getting chemotherapy. So do they have any long-term effects from the chemo they received? And then how are they doing with the psychosocial aspect? Because once somebody has a cancer diagnosis, it is forever with them for the rest of their life. It's kind of always like this bird sitting on their shoulder or this weight on their shoulder of, is it going to come back? Do I need to be scared that it's coming back? They might get a cut on their finger and think, oh, my cancer's coming back, right? It changes their mentality of how they think about things. Okay, why don't you guys take a break and we'll talk about hormones.